talk a little bit about my accident because I've loved being a physician and I've learned everything from being a patient that changes how I am a physician today. Then I'm going to fast forward to today, where I'm the medical director of a pain clinic at Laguna, Honda. Finally, I'm going to end with a little bit about Buddhism, because that's really what's brought me comfort, and that's what taught me some tricks to deal with human suffering. So anyway, that's what I'm going to do. We're going to start with the traumatic brain injury, which is my own. You'll see there's some wild pictures of the accident. I'm not looking at that, but I was just really interested in, once again, looking at what kind of injuries I sustained. Because I'm a doctor, I can't help but being a physician. So I wanted to look at all of my medical records, and I pored over them at one point, and I want to put this material to rest. So thank you very much for indulging me. But I thought I could look through it one more time and figure out what I'd learned really as a physician. So this is about my traumatic brain injury. And it happened, the accident happened on the Golden Gate Bridge, which many of you drive over many times each day. This is 1937, and that's Henry Ford in his Model T, going across the Golden Gate Bridge. Facts, there are 1.8 billion crossings since the bridge was opened in 1937. There are 40 to 50 million crossings each year. Since 1970, there have only been 36 fatalities, 17 from head-on collision. So the odds of having a head-on collision and dying are about zero. Nonetheless, it does happen, and it did happen to me. And it did happen to my daughter and my dog, both of whom are fine. I'm pretty fine. I was taken by helicopter to John Muir Hospital. My daughter was taken to Marin General, and my dog was taken to the emergency room at San Rafael. His bill was only $1,000. My daughter's bill for one night was $10,000, and my bill for one night in the hospital, just the hospital room, not counting any of the doctor's charges, was $100,000. So at the beginning of the ride, and I thought there would be some medical people, so bear with me, I'm sorry, but I just wanted to show you that I was doing fine at the beginning of the ride. I could speak in full sentences. My Glasgow coma score, and you're going to find out what this means if you don't already know that, was perfect. I was speaking in full sentences. I could give the ambulance driver my daughter's social security number, all of the medication she's on, all of our various grandparents who were related to her and needed to hear about her, and the vet's number. And by the end of the trip, however, my blood pressure was tanking. They must have given me some pain medication, is all I can figure out. I had 10 out of 10 pain. So I can't remember any of this trip, but I do remember that I wanted to stay conscious and alert so that I could find out that Sabrina had landed fine in Marin General. So I said to the ambulance driver and the helicopter pilot, don't let me pass out before I hit the ER at John Muir. Anyway, when I got to the ER, I was really tanking. My blood pressure, for those of you who aren't medical people, that's really low. That's getting dangerously low. And by that point, I was still able to speak in sentences somewhat, but I had shallow respirations. I was very pale and shocky, and I had decreased breath sounds on the left side. You'll see why. And all of my extremities were obviously broken. Initial labs, this is all just to say that my chest didn't look normal. My pelvis didn't look normal. My femur didn't look normal. I had bilateral compound comminuted fractures of my ankles, and my hematocrit was starting to tank. Now, this is a bad sign. We don't like to see hematocrits down about that point. That's about 10 points lower than I normally run. This is my chest. I can't really see that picture, but my intestine is all the way up in the left chest wall. Do you see my right chest? It's got that black area, that's normal, and that's where the air is, but I don't have any in the left chest because my colon and my spleen actually were in my left chest. And that was my pelvis. I have about 10 fractures in my pelvis. That's the left forearm. That's the left leg. So initially, what did they do to me? They gave me uncross-matched blood, which to me as a physician means that I wasn't doing too well. We don't ever give anybody uncross-matched blood. That means we try to figure out whether you're going to coagulate or not, or whether you're going to react to some blood. So they need to check what kind you have. But I hit the ER and they just started pouring the blood into me. And then they triaged me to the OR to deal with all of these following problems: blunt abdominal trauma, four-extremity fracture, probable left diaphragm herniation, and acute hypovolemic shock. In the OR, and I love this, my diaphragm was repaired and the abdominal viscera were pushed back into place. Now, they couldn't sew me up because my stomach had expanded so much, so they just put plastic wrap over everything, and they put a wound vac on top of it, and lo and behold, and they sewed up my radial artery had torn, and my hepatic artery had also torn. And all joints and skin openings were IND'd, and they placed external fixators, which just means they were holding all of my extremities in place. And the next management, I got left and right chest tubes the next day. I had open reduction and internal fixation of everything, as far as I can tell. And I was transfused with 42 units of packed red blood cells. Now, the normal person has about 12 to 14 units of packed red blood cells, so I received about 3.5 times my blood volume. And I got fresh frozen plasma in factors 7 and 8. That was all because I wasn't coagulating. And the next management, they placed an IVC filter. That's just so that I wouldn't get a blood clot, theoretically. They took me back to the OR because they lost the sponge, and they found the sponge. They did the primary abdominal closure. They did a tracheostomy. They placed, which is just a hole so that I could be on a ventilator long term. And they placed a peg in my stomach so that they could feed me. And I was in the ICU for another 39 days. Where was I? That's what I'm wondering. That's really what I have to wonder about that time. The short answer is I was asleep for the next 45 days. Brain biology, a little review for those of you who know nothing about brain biology. We have about 100 billion to 1 trillion cells in the human brain, and of those, there are billions of synapses or trillions of synapses, and each neuron is separated from another only by 6 degrees of separation, meaning that it's a very small space, so everything really interacts with one another. And I'm mostly interested in traumatic brain injury because this is what I have. But also, the same centers in the brain that got injured in me are exactly those centers that spirituality seems to appeal to, and also that pain thrives on. So if we can find a way to deal with those centers, we can deal with those two problems, meaning pain and suffering, and how to remedy those. So what is a TBI and who suffers from them? 1.7 million people in this country, not including our troops overseas. And it's usually men, and it's usually the young and the very young and the young-ish, meaning teenagers. And the people who are most likely to die are the old people, 75-year-old and greater. What are the causes of TBIs? You can see it up there. I can't really see that slide, but about 30% are from falls. Those are the old people and the young people, and about another 25% are motor vehicle accidents. Being struck by or against an object, that's shaken baby syndrome, or it's contact sports, football injuries. You can see other causes. It's really a ubiquitous problem. What are the mechanisms of injury? The type, duration, and intensity of the forces really determines what happens. And in most cases, it's a combination of acceleration and trauma, direct trauma to the head. And something happens initially when the blood vessels are stretched and often torn, and secondarily or diffusely way long after. So changes go on in the brain for years, even after the initial insult happens. The pathology can either happen inside of the brain tissue or outside of the brain tissue, but inside of the skull. It can either be focal or diffuse, and it's focal if it's a particular part of the brain that's hitting up against something, like the orbital frontal cortex, which is the lower surface of the frontal lobes, and the anterior temporal lobes. Both of those are areas that are often involved, and they're areas that are mostly involved in social behavior and emotional regulation, also decision-making and decision-making. Again, diffuse is a much more ubiquitous form and more lasting form of injury. And that's when the axons from the brain are actually pulled apart and torn, and they die. And they project into the cortex. So they're the way that the brain has to communicate with from one part of itself to another. And they're mostly involved with decision-making again. But this is why people with brain injuries are so often have impaired top-down control. Nothing is quite coordinated. And this is a picture. You can see that when your head goes back and forth, which is often what happens when you've got a motor vehicle accident. And you can see the picture over there of the cell body, and it twists, the axon twists, and ultimately dies. And that's just another picture of the cell death. And what's the problem with cells dying? It decreases the perfusion pressure to the brain. Now, what is the purpose of blood or the heart beating in terms of what the brain does? If the heart doesn't beat, or if there's no perfusion pressure, you can't get oxygen to the brain, and you can't get any nutrients to the brain. So parts of the brain just cease to work if the perfusion pressure drops too much. And that's the biochemical cascade. I am a doctor, and every now and then I love organic chemistry. And this is one case where I just had to put this slide up because it shows me everything that I don't remember anymore. This is the Glasgow Coma Scale. And originally it was what was used to diagnose how severe somebody's traumatic brain injury was. And you can see it goes, I think, bottom motor is 6, verbal is 5, and eye-opening are 4. So the most you can get is 15. And getting a 3 is really bad. I've seen people in the emergency room who have a 3. You don't want to ever have a 3. It's not really compatible with life. But given that I had a 15, one would think I didn't have any brain injury. Again, we've got another way to look at this. Glasgow Coma Scale is on the far left. PTA means post-traumatic amnesia, and that's the point at which somebody is injured from when they have the first consistent recall of who they are, what's going on, what's happened. They're oriented to time and place continuously. And LOC is loss of consciousness. So on the basis of looking at those two criteria, I obviously had a severe brain injury. Based on Glasgow Coma Scale, I had a mild injury. Medical complications. What are the medical complications of TBIs? Post-traumatic seizures. They happen often, but we give everybody anti-seizure medicine for the first 7 days. Then we stop it because it does more harm than good. If you've got a late seizure, meaning more than 1 week out, then you've got a 50% or greater chance of having another one. DVTs, 54% of people who have a TBI get DVTs. Heterotopic ossification, this is what I had horribly, but it can happen in any joint, and it's when the body lays down bony matrix, so it sort of freezes. My elbows were out straight, and I had to get them reamed out, so to speak. And the people who are most affected by this, I thought this was great, are football players who are under 18 who have TBIs. They often get, exactly like I got, meaning with their arms and legs totally outstretched, and they've got to ream out, they've got to take the bony matrix out, or else you can't ever move again. Long-term consequences, they're cognitive consequences, post-traumatic depression, agitation, stress, insomnia, fatigue, post-traumatic headaches. Everybody should look at this. And the Stroop effect refers to the fact that it takes less time to read the word yellow than it takes to say the color of the ink that word is written in this case, green and red. We'll come back to that later. Anyway, they normally do 1 CT on the first day. I had a couple of big bleeds, and so they want to take you back and look and see how they're going on day 2. And if they're growing substantially, then they'll do a craniotomy. They'll just take your skull off so that the brain has some place to grow. And or they will try to evacuate the bleeds entirely. But in my case, they were staying pretty stable, and there wasn't any mass effect, meaning I wasn't about to herniate my brainstem. Both of the bleeds increased, but I only had local only, no mass effect. What are the predictors of persistent vegetative state? Now this is what my family was all very interested in, meaning I was asleep for 45 days. Where was I? What was happening? Was I ever going to come to? Of course they were worried about that, and I would be too, but I wasn't anywhere to be worried about it. So unresponsiveness from the time of impact. I wasn't unresponsive. I didn't have a cardiac arrest. I did have hypoxia, and I also had hypotension. One episode of having the blood pressure drop below 80 is corroborated with a 50% increase in mortality and a 50% increase in severe disability. So it's not good to either be hypoxic, which just means not enough oxygen, or hypotensive, which means not enough blood pressure. Again, perfusion pressure to the brain. Short transport times also don't help. And I think that's because they try to intubate people in the field, and when we intubate, we often make the person hypoxic, unfortunately. So I think that it's directly related to that. But people who are flown to their transport destination do best. What is the prognosis for TBI? Initial Glasgow Coma score, the higher the better. Duration of post-traumatic amnesia, fewer days the better, that makes sense. Sex, female, better, that makes sense. Age, younger, better, that makes sense. Years of education, more, better. I think that's just a statement of the fact that our medical system rewards class. What are the outcome measures? You don't need to know this. And this is my MRI scan. Again, we can't, I can't get over there to make it come to, but you don't need to, I don't need to look at that again. And you obviously don't need to look at it if I don't need to look at it. But it just shows my DAI. And this was done about 2 years after the accident. This accident happened about 4 years ago, just so you have a sense. And the reading, however, was important. And it's interesting to me as a physician that for some reason, when I read this reading, constellation of findings consistent with severe cerebral traumatic insult, I was actually relieved. And I couldn't understand why I've been relieved. And I think I've had more patients say to me, if only I had heard the actual words of how bad it was. And I think then I really knew what I suspected all along, which is that I'd had a really serious and severe cerebral traumatic insult. But I hadn't known that until 2009. None of my doctors told me. And I was so blissed out that, of course, I didn't realize that I was really out to lunch, really out to lunch. Let's go back to this test. Okay, so I'm going to time you for 10 seconds. And just the first 10 seconds, everybody should just read the words across the top to yourself. And I will count to 10 and I'll tell you. And keep track of where you got to, okay? Starting now. Okay. And now on this test, look at the color in which the word is written and say to yourself the color of the ink. In other words, green, purple, okay? And again, I'm going to time you. Go. Okay. Did you, isn't that interesting? I think the explanation of the Stroop test is that the brain can read, it reads automatically, and it automatically knows what blue should look like. So it has to override that blue color when it has to say what color the ink is. It's got to automatically override that. And the brain doesn't want to do that. It takes a lot of energy. So that's why it takes you so much longer to read. The Stroop test is a neuropsychological test that's given to those people who got traumatic brain injury up the yin-yang. I must have taken, I can't think how many times I've taken this test, but many, many, many times. And it's also considered to be a great test of cognitive flexibility, processing speed, selective attention, memory, executive function. Time scores decrease with age, and they increase with frontal lobe problems, executive function problems, neurodegenerative disorders, TBIs, Parkinson's disease. And this is the part of the brain that seems to be implicated by the Stroop test. We know this because we've got functional MRIs that can show us exactly what part of the brains are working when you do a Stroop test. And they're the anterior cingulate cortex, the bottom part of the frontal lobes, the prefrontal cortex, and those are the parts in yellow right there. I have some random thoughts at this point. I had 17 operations. The risk of an untoward accident or outcome in each was about 3 to 17%, depending upon who you read on surgery. I spent 39 days in the ICU when they do an average of 179 procedures a day with another 1 to 2% error rate on each of those procedures. And I spent more than one continuous year in the hospital. So those are the facts and figures about my 1 year in the hospital. So I read this wonderful book when I was in the hospital called The Checklist Manifesto. Has anybody read it? By Atul Gawande. He's a surgeon at Peterbent Brigham, and he also is a great writer for the New Yorker. And the Checklist Manifesto came about because worldwide there are about 250 million operations performed each year, which is more than twice the global birth rate. The death rate from hospital-based surgery is about 10 to 100 times that of the death rate from birth. In the US alone, there are 150,000 deaths that are the result of surgery, which is about 3 times the number of all traffic fatalities. Now, I never knew that. Half of those are preventable by some person's analysis, and half of all ICU errors are preventable. So, WHO brought together 8 hospitals worldwide. 4 were from resource-rich countries like University of Seattle, Washington was one of ours. Toronto General was one of ours. And 4 were from resource-poor countries like the University of the Philippines in Manila, Tanzania Hospital, which has where the annual income of all of Tanzania is only equal to 1/10 that of the annual output from the University of Seattle, their annual budget. So they were trying to come up with a way to lower the error rate. And they came up with what I consider no-brainers, meaning give antibiotics on time if they're going to be given. Pulse ox was available and working. That's the way we check to see what kind of oxygenation somebody has in their blood. That's directly related to what their perfusion pressure at any point is. IV access was available if it was going to be needed. That there'd been some discussion of potential airway use, meaning were they going to have to breathe for somebody? Patient identity and procedure identity had been verbally confirmed. That's a no-brainer. And an instrument and sponge count happened at the end of the procedure. So these are all no-brainers, we think. Now, don't you think as a surgeon they're no-brainers, Bill? So in the, the lead-up phase to instituting this checklist, the 3-month lead-up phase, more than this, I can't see what that says, but I think they missed one of these items in more than 2/3 of the cases, whether they were resource-rich or whether they were resource-poor hospitals. So once they implemented this checklist, major complication rate for surgical patients fell by 36% in all 8 hospitals. And these were serious complications. You had to almost bleed out, or you got such a bad wound infection that you ended up in the ICU, or, they cut off the wrong leg, whatever. Infection rates fell by about half. Death rate fell by 47%, and the number of patients having to return to the OR fell by 1/4. So this checklist was remarkably successful. So what are my thoughts? My thoughts for me as a patient is that I wouldn't be alive today if anybody had made a predictable mistake in my first month, particularly when I was in the ICU. after TBI, I'm still me, but I don't know exactly what I'm capable of. And I may not remember that I'm not capable of something that I think I am. Luckily, my values and thoughts and heart are the same as they once were. Number 3, people tend to adapt the way they've always adapted. Number 4, what is helpful are tools to deal with pain, identity crises, constant change, not knowing, and enjoying just the smallest things. And for you and me, and this is assuming that some of you are healthcare providers, try to figure out what mistakes you often make and develop checklists to protect yourself and other people. Remember that the most important thing for the person or patient, or I would say this is true whatever your walk of life is, the most important thing for the people around you is being a happy person. Figure out what you need to do to be happy, figure out what you need to do to make other people on your team happy, and just do it. And the most important member of the team is probably the person you think is least important. That's in the hospital, that's the CNA, Certified Nursing Assistant. Take a long view on the time for recovery, believe in miracles of life, the body, and people. Remember that it all happens on the in-breath. Get disability insurance. I don't care about life insurance, you don't need it. You do need disability insurance. Watch the lifetime caps on health insurance. No kidding. Watch your lifetime caps. If you are with an insurer who has a lifetime cap, get a different insurance plan. Avoid the left lane on the bridge at all costs and develop your own tools. So I will now fast forward to the pain clinic where I went back. You'll see, no, we haven't seen the clip of the movie. Anyway, on the day of the accident, I was driving home from Laguna, Honda, where I'd worked for 20 years. And you know, I did a variety of things, and I never thought I was going to stay there more than a day. But I somehow managed to work for 20 years, and I loved it. I have a real love-hate relationship with that institution. That's all I can say. Anyway, I'd been there for so long, and they treated me so beautifully. When I was injured, you know, the medical staff and all the hospital came together and made origami cranes, and they made 1,000 of them. I've still got them in some storage bin somewhere. I still have to figure out what I'm going to do with them. But it was wonderful. And the institution as a whole and the Department of Public Health came up with over a year of donated sick time so that I was paid fully for my first year in the hospital. And the director of public health himself gave me 2 months of his sick time. And he was a single parent of 2 young children, so donating 2 months of sick time, as anybody knows who's got young children, that you don't want to do. Anyway, I felt like I was so supported by them. So when I went back to visit, they asked me whether I would consider coming back to work. And I said, you know, I feel like I just squeaked out of there. Thank you very much, but no, thank you very much. But when I was cleared to practice medicine again by my physiatrist, I thought, I still owe that institution much in the way of my files. I was chair of the ethics committee, the med exec committee. You know, I had so many files on so many people that I needed to go back and do something about my file. So I thought, the medical director came up to me and said, would you be willing to be chair or run the pain clinic that we're going to start? Now, pain was becoming a national problem, and it certainly is a national problem, bordering on crisis, that we've got very mixed feelings about. On the one hand, pain has now become the 5th vital sign, along with blood pressure, heart rate, temperature, respiration. So somewhere we use it to determine is this patient alive or dead? So the fact that pain is now the fifth vital sign puts pain somewhere on that continuum of alive or dead. But on the other hand, the government is very concerned about the use of chronic opiates for people with chronic pain, and it's mostly concerned about the diversion of those opiates into the subterranean marketplace. So Laguna Honda, as all institutions, was under some regulatory demand to clean up its act around pain, but also it had an ethical feeling that it wanted to do more for its pain patients. So when she asked me whether I would be the director of this clinic, I thought, oh God, anything but pain. I do not want to do pain. But nonetheless, thank God, I said yes. I just said yes because that was my practice of just saying yes. And so I became chair of the pain clinic. And this is our staff. We've got 2 doctors, 2 nurse practitioners, psychiatrists, psychologists, an activities therapist, a physical therapist, occupational therapist, a doctor of pharmacy, and we love it. We're having so much fun, and the patients are having so much fun. So what do? Here we are meditating. We start each session with about a 10-minute meditation for us, and we're just very quiet. Then we talk about patients that we're going to see, and we go in. I think there we're in seeing a patient, and our goal is to just listen to that person, find out what their pain is, how they're suffering with it, how it disturbs their life or doesn't, what they can see or what they would like to change, what a goal for treatment for them might be. And we try to listen really closely without having any kind of expectation. So for one person, his goal of treatment was that he would get to Skype with his mother, who lives in Mexico, who's illiterate, whom he hasn't seen for 25 years. And I thought that was a great goal. That's a great goal. And another person just wanted to be able to sit up for 2 hours so that she could go out on a bus ride. So after we listen to the patient, then we come out and decide what we can offer them for treatment. But the first day, we offer everybody acupuncture, healing touch massage, and music therapy. And they all take it. And they all stay for three hours. All the wheelchairs are together in one space. And they end up, you know, just coming and staying only for the group treatment. They love the group treatment. So pain, what is it? I love this definition. Because this really gets at it. An unpleasant sensory experience associated with potential tissue damage. I'm going to read it as I can read it. Pain is always subjective. It is unquestionably a sensation in a part or parts of the body, but is also unpleasant, and therefore it is always an emotional experience. Factors influencing pain and how we experience, you can read these, but they're biological, psychological, and social reasons why somebody experiences pain differently. And the point of all of this is that pain is experienced very much subjectively. What I say is pain, you may not experience at all as pain, but nonetheless, my pain is valid. Nonetheless, your experience is valid. I think this theory is very helpful. It was arrived at by the Institute on Medicine, which is the think tank for the federal government that's trying to come up and diagnose the main problems that we have in healthcare. Pain certainly is one of those main problems. I think chronic pain syndromes do not need to have an obvious cause, but are associated with changes in the central nervous system. That's important. And the brain is not a fixed system. Rather, it's plastic. This is the neurology of pain. In the old days, we just thought it was the result of feeling the fire. Now we know that that it's modulated from the brain. This is more of the same. This is the Institute on Medicine conclusion of their recent study that hasn't gone to press yet, that basically says that we need to transform how pain is perceived, both by the people who experience it and by those who care for them. And this is pain by the numbers. Now we get to Buddhism. And I'm going to wrap it up very quickly. But I found Buddhism enormously helpful because by the time I was in my accident, I'd already experienced everything I needed to experience about pain just by sitting in the zendo. It came and went. It came and went. And Buddhism can be succinctly categorized according to the Four Noble Truths. There is suffering. Birth, death, life, there is suffering. Old age, sickness, and death, there is suffering. And the Eightfold Path, which is the way out of suffering, according to Buddhism. Why Buddhism? I had the good fortune to meet His Holiness the Dalai Lama, and also I live in a community that fortunately was started by Suzuki Roshi. Both of those people are wonderful human beings, and wonderful, wonderful. And I think if there's hope for the human race, it rests with people like these who know what practice is all about and who can really transform their own and other people's suffering as a result. This is His Holiness in me. And this, I love this quote by Suzuki Roshi that, you know, in the Zazen posture, you're able to accept even disagreeable experiences. Again, that quote, and that's Tassajara. For those of you who've never been there, go there. It's beautiful. What's the purpose of practice? I think the purpose of practice is just if we can transform one person with a kind word, therefore ourselves with a kind word, we've added something of benefit to the world. I'm studying koans these days, and they're like a path in the woods. How to not use your mind, how to get rid of your mind. And I will just end with my koan. And you can just read that. I don't want to read it to you. So why did I end with Buddhism? Because it's been very good to me. And again, like I said, I think in the accident, I've been given a wonderful opportunity to make my life be available and obvious to many people. And I've tried to do that with some kind of dignity. People have always asked me, why did you just say yes to being filmed, especially in the bathroom? And I said, you know, that's the least of it. That is really the least of it. But my early orientation was just say yes, and that was how I tried to meet everything. I didn't say yes to the accident, but I have said yes to the fact of the accident. I do say yes to the fact of the filming, and I do say yes about every experience that I have, that I can share my experience of what it's been like to be a patient or be a doctor in this time and era. So thank you very much. And Janae will now tell you how you can find your center. That's how I've found mine.